All right, welcome everyone. Happy World Preeclampsia Day. I say happy because there's been some good news in the headlines that we're going to talk about today. It's also a great day because we have some amazing guest speakers with us today. I'm Cara Belt, the founder of End Preeclampsia, and we're coming to you today to talk about research, preeclampsia, research in pregnancy, biomarkers, all kinds of great sciencey stuff. We're gonna make this a palatable sciencey discussion that you're all gonna want to listen to and learn more about what's going on in research in preeclampsia. Joining us today, I'm gonna let each of them introduce themselves, but a quick review here. We've got Dr. Maggie Little from Georgetown University, we've got Dr. Tom McElrath from Harvard, and we have Doctors Donna and Mark Santillan from the University of Iowa joining us to talk about all of these great things that we need to talk to you about, our members. There's sort of a myth that there's not really research being done in preeclampsia, and it's just not true. And we've got some actual researchers here in front of us today. They're going to tell us a lot more about that. So I'm going to start off and have Mark and Donna introduce yourselves. Tell us a little about you.
Okay. Hi, y'all. My name is Mark Santillan. I am a maternal fetal medicine or a high risk OB specialist at the University of Iowa. I'm also a preeclampsia researcher. At the university, I have several roles. I'm an associate professor here in OBGYN. We're involved in several programs at the university here, including the Institute for Clinical and Translational Science and the IDDRC, or the Intellectual and Developmental Disabilities Research Center. My work in the lab is focused on preeclampsia and the early mechanisms of preeclampsia and what we can do to manipulate those early mechanisms of preeclampsia for prediction and for therapeutics and hopefully prevention.
And I'm Donna Santillan. I'm a molecular biologist by training, and I perform translational research. And so my research spans from the bench to the clinic. And in addition to doing that, my work in preeclampsia, I also run our Women's Health Tissue Repository, which is one of the ways that we help facilitate research on preeclampsia and other pregnancy-related diseases.
Great, thank you. Dr. Little.
Hi, everyone. I'm Maggie Little. I'm trained as a philosopher who does very applied ethics. So much of my life has been working on ethical issues in the care of pregnant women. So how do we do research that's sorely needed in a responsible way during pregnancy to make sure that moms and their babies have the best evidence-based care that we can give them? I've been working with CARE's organization for a bit now, and one of the small pharmaceutical companies that we'll be talking to about helping them to think through what the best practices might be to design to support pregnant women as they participate in research trials if they decide to do so. It's great to be here.
Thank you so much. Dr. Tom McElrath. Hi,
good evening. So I'm Tom McElrath. I am a maternal fetal medicine specialist at Brigham and Women's Hospital in Boston, which means I see and care for patients both as outpatients and on our inpatient service. I'm also professor of obstetrics and reproductive biology at Harvard Medical School and of epidemiology at the Harvard School of Public Health. Additionally, I'm the principal investigator on our Life Codes Biobanking project, which is a project designed to collect specimens from pregnant patients in order to do translational research regarding pregnancy and pregnancy outcomes. My lab specializes in looking for biomarkers for pregnancy outcomes, particularly preeclampsia, and also in looking at environmental exposures that can lead to adverse pregnancy outcomes, including preeclampsia.
Thank you. I appreciate all of you for sharing your time with us today and your talents, and also for the work you've done throughout your careers devoted to maternal health. I know that I am eternally grateful for all of your time and talents, and I know our members are always so grateful to have you in front of us speaking so that they can have some sort of insider knowledge and learn what's going on behind the scenes. Just to be clear and upfront, we do have a few conflicts or potential conflicts to share with our members here. As Dr. Little had mentioned, we're going to be talking about a small biopharmaceutical company. Preeclampsia is consulting with them as a patient advisor to some work that they're doing. And I know Mark and Tom and Maggie also are consultants with that biopharma called Comanche. We have a couple of other, Mark, did you have one that you wanted to mention, conflict? Mark and Donna?
Donna and I both hold patents in the realm of preeclampsia with regard to prediction and with regard to therapeutics.
And then we have I just have a quick slide I will share for Tom with a few potential conflicts as well. All right, great. And then I can post those later as well, just so that the audience has access to them. So thank you all for that. We're going to be talking in more detail about all of these things. So a few things we want to talk about today is just research into preeclampsia in general. Like I mentioned at the top of our talk here today, I think that a lot of patient members don't think that there's really much research going on. And part of that is because we maybe don't have something, tangible to see from that research. So I just wanted to talk a little bit about what kind of research is happening in preeclampsia. Mark, can you start off here?
Sure, be happy to. It's too bad that that's out there in the lay audience, because in truth there has been a lot of active research in the field of preeclampsia. The problem is it's such a complicated disease. It's not as simple as mild and severe, or with or without severe fevers, or early or late. We know now, because of the research that is going on, that molecularly, preeclampsia is very much like, and this association is going to sound weird, but like cancer. You've probably heard on commercials, in a sense, that this particular drug works for triple negative breast cancer. And in the sense that there are molecular markers that identify these different types of breast cancer. And so preeclampsia is equally as complicated and equally as molecularly different. We're just not there yet. And what we know now from a lot of research from friends that Tom and I have with regard to their work in the heterogeneity of preeclampsia, not only clinically, but molecularly, is really important. So that also makes the challenge of some of the biomarker work tough. Our lab has been focused on one particular biomarker that our patents are on with regard to vasopressin and the mechanisms around that. But Tom, maybe you want to talk about the complexity of the biomarker stuff that we published in the Nature paper?
Well, no, for sure. I think it's probably only been in the last, maybe 7 to 10 years that people have begun to realize that preeclampsia isn't just one disease, that it's really several diseases, if not an entire syndrome. And that's really limited things, because it's very hard. If what you've got is 2 or 3 real separate diseases, and you're searching for one biomarker that's going to predict 2 or 3 separate diseases, your search is going to be very difficult. It's kind of like finding one marker that could predict fever. There's dozens of reasons you're going to have fever, And if you're looking for one thing that's going to predict them all, your one thing is going to be pretty non-informative. And that's really been the case with preeclampsia up until probably, I guess, I might even say the last five or so years. Now we've begun to realize that probably the disease that occurs before 34 weeks is in many ways different from the disease that occurs more towards term in pregnancy, and that it's probably more informative to divide these two pieces of the condition to look for separate biomarkers for each. And that's been informative, and that's what's helped us move along with markers in a variety of arenas, whether they're protein-based or RNA-based or combinations of the above. I think now it feels almost as if the research into preeclampsia is actually exploding a little bit, because there's so much out there that is being published on a regular basis. You have to wonder a little bit, it's almost as if it's too good to be true. All of these things can't all work, so we'll see what sort of shakes out after time. But I think we've really turned a corner in that there's a lot that's coming online, and that will be more informative in the near future.
So to that note, I think Mark and I were on the phone talking, and there are, as of last week, 703 preeclampsia clinical trials. If you log in over at clinicaltrials.gov, 703 ongoing studies that have, the word preeclampsia or HELP syndrome or eclampsia in the title. So 703. I think that number will be shocking to most of our members. It was shocking to me when Mark mentioned it to me. So, and I think that's a good note if you're interested in potentially enrolling in research or being a participant. You can go check out clinicaltrials.gov to see if there's something going on at maybe a university hospital near you. Right. So let's talk. Yeah, go ahead. No, go ahead.
No, I just, what Tom said was perfect in the fact that it's an exciting time to be doing research in the preeclampsia field, because things are expanding quickly. And some of the tried and true traditional clinical trials have gotten off the ground for us. And there may be real therapeutics that are out there, because heretofore, as many of you in the audience already know, you've probably heard all your life, but anytime you've thought about preeclampsia, the only cure is delivery. And we know, even though that's not true, you can get it postpartum as well. And so being able to mitigate, because of these new biomarkers, because of these new mechanisms that we're all trying to identify, we're getting a little bit, it's like taking steps closer to maybe blocking a particular pathway, such that maybe we could prevent preeclampsia. So it's incredibly exciting that we have this flood of information. What do we do with it now?
You have all kinds of new fans, Mark, from the postpartum preeclampsia crowd, who often feels a little orphaned in all of the conversations that we have, and the sort of the myth that once you deliver the baby, everything is fine, which we know is not true in many ways. But the postpartum preeclampsia gals are all singing your praises right now. So let's talk a little bit about biomarkers. There was some big headline this past week, Friday, actually, I think, where a company called Thermo Fisher received FDA clearance for a biomarker test. I think that's probably the terminology that our audience would understand. And it is, would one of you take up the torch and discuss that?
Sure, I can take a stab at it. So it's important to understand what this test is and what it is not. So this test is a test that will be used to aid in diagnosis and aid in understanding the risk that a particular patient has when she already is under suspicion for having preeclampsia. So this is going to be something that once a patient has been diagnosed with high blood pressure and potentially the other signs and symptoms of preeclampsia, this test would then be used to try to determine, does she really have preeclampsia, or particularly does she have the really kind of more dangerous severe form of preeclampsia, and the more severe form that might put both her and her baby into some type of jeopardy? Or does she have something that might be high blood pressure or pregnancy, something less severe that she might be able to be managed from home, or with a little less sort of medical intensiveness. What this is not is a test at the beginning of pregnancy that's going to tell you whether you're at risk later on in pregnancy. So this is really only a test to help aid in diagnosis. It's not something that's going to aid in determining what might happen weeks to months away in somebody's pregnancy. So it really won't be part of prenatal care the way that a lot of other tests are done, particularly at the end of the first trimester in prenatal care. This will be a test that will be done if somebody is potentially going to be hospitalized or treated or delivered, in fact, for preeclampsia.
So this is a tool in the clinician's tool belt to aid in
well, it's a really important tool. It's a big step forward because unfortunately, most people don't realize this, but the diagnostic criteria for preeclampsia have their origins in 19th century medicine, I think, with the hypertension component and then the proteinuria component in the early 20th century. So very few other diseases in contemporary medicine really have these diagnostic criteria that are just almost, if not over 100 years old. I think maybe appendicitis might be an example, but this disease has really not had it's time to be brought into the contemporary medical age. And I think having this test, particularly having a test that in part reflects the underlying physiology and the underlying pathology of what's happening with the condition, really does sort of accelerate the physician's understanding or our understanding of what preeclampsia is and how it may push us forward, I hope, because we really sort of have been behind where a lot of our colleagues in other medical fields are with regard to diagnostic acuity and diagnostic ability. I don't know, Mark, what do you think?
I would agree, and the fact that clinically Tom and I are stuck in, without any molecular tests or anything, that we're stuck in 1800s medicine is a little behind it. I mean, this speaks to kind of where the focus of research has been in the past. For example, maybe an example that many of the audience may already know, heart attack, right? You can clinically figure out somebody's having a heart attack if they're having crushing chest pain, the arm, the pain down the arm.
Figure out
a man's having, right? Because a woman.
Thanks, Donna. Thanks, Donna.
Thank you for keeping me honest as per usual. The classic male symptoms of a heart attack with a crushing chest pain down the left arm, that you could be pretty sure that man is having a heart attack, but there's a confirmatory test called a troponin, which clinicians get all the time. And when you get that positive, they're like, yep, that was a heart attack. And then you do other tests to, find where this lesion was. Preeclampsia has never had that. And there's a long list of less prevalent diseases, prostate cancer, and heart attacks, and even colon cancer that have these confirmatory tests that preeclampsia has never had, and the fact that we have this now is a big jump.
If I can add in, Kara.
Yes.
While I hang out with the scientists on preeclampsia all the time, I'm going to ask my colleagues to correct me if I get something wrong. I too just thought this was an enormously exciting announcement, one that we've been hoping and waiting for. So it's a diagnostic test that has already been used in Europe, in England and Germany in particular. And their results have been really quite extraordinary in the usefulness of it and how much it can actually tell us. Not doing anything to cure, but as Mark was indicating, when you have a test that really gets at the the molecular basis of a disease. That's so helpful for a few different reasons. One is that if somebody really does have preeclampsia, but has not the usual presenting classical 1800s symptoms. And Kara, you've talked a lot with your members and with our group, educating us about how preeclampsia doesn't always follow that set of clinical indications. You can have it without having what looks to a doctor like high blood pressure, or you don't necessarily have the protein in your urine. All those sorts of things, as they were saying, it's sort of a syndrome, and how can we tell? So if there's a suspicion but it doesn't fit the classic, ultimately this diagnostic can be used to really pinpoint and say, at least for this type of preeclampsia, which is probably one of the sort of dominant types, if I understand it correctly, we can say yes. And that means you can go under the kind of management that may really help. As also, when we've got diagnostics like this, we can give the reassurance when it's negative. So, Mark, you were mentioning the fantastic test for heart attacks. I remember once, I'll tell a quick story. I was traveling, I had terrible chest pains, terrible. And finally at 2 a.m, I thought to myself, I'm being an idiot. You're supposed to go to the ER when you have this. And I remember that the women's is not typical. And I'm like, and I made my husband take me in. Well, it turns out absolutely fine. I just had bronchitis that really was seizing the lungs up and made it very painful. But it was great because they gave me that test that Mark is talking about. 10 minutes later, they say, we know for sure your heart is, you didn't have a heart attack. Then they did the X-ray on the lungs. But we shouldn't understate the relief that we get when we can put away the worry that maybe this is something quite devastating. So very, very interesting. And again, the data out of England and Germany indicates that there's a lot of information that could be garnered from the test when it's repeated to see what course it's taking and the like. So I think it was a day to pop the champagne myself when the news came through.
Yeah, we had a number of members who said, they cried, tears of hope, maybe for their children who may have their own children someday.
Mm-hmm.
And also a little, there's some of them who wish this was something that was available to them, sooner. And we know, obviously, our members in a number of places in Europe have had access to some similar tests. And like you said, they've been used effectively. I think we think often about the patient who's, going to get really, really sick, and really fast, and having this might get them into care faster and prevent some, terrible outcomes. But I think it's also equally important for those who aren't maybe going to get sick, or at least not sick fast, that they aren't tossed in the hospital for 3 or 4 months, because there is a lot of trauma that comes from, being away from your family, not being able to go to work, being in the hospital, feeling like a sick patient, whether you are or not. So I think on both sides of this test, there's some relief. Yeah.
And Kara, as you're talking about like being in the hospital and away from your family, in some places like the very rural states, you could be in a hospital very far from your family. And so this can help keep you out, like you said, or it can also help you get to the places that have the care that you need, because we have these large maternity care deserts where there are counties with no labor and deliveries, and you have to travel hundreds of miles. And so to know that this headache is a real headache and it matters, and you should be transported versus you should not, really can make a difference in just getting you to a place that has the level of care that you may need.
Yeah, definitely. For our rural members, it is a struggle, right? To drive 3 or 4 hours, maybe more, in some areas, just for their regular care. And then when something, when a symptom comes up, are they going to go and be sent away? They're leaving their kids, they're having to find somebody to care for them, they're having to call off work, all of these things. yeah, I think it's going to be really impactful. And we've been waiting a long time, right? Some areas in Europe have had some of these tests for a while. Tom mentioned that, this is going to be used when there's a suspicion of preeclampsia, when something's just not right, whether they're starting to have symptoms. So we're talking, late second trimester, early third trimester, or whenever that might occur. And I think it's important in sort of talking about the timing of this test. This isn't a test that's commercially available, even though we had this big headline on Friday. This isn't something that someone can go and call their doctor and ask for that test tomorrow, right? But just from what you've seen in your careers, what kind of, I'm no promises here. I know that you're not involved with this test in any particular way, but like, what do we think like availability of this test looks like? When are we going to see this?
So hospitals are going to have to decide that they want to offer it. So perhaps if your membership can be supportive of that, that would be very helpful, because it's not all tests are available in all hospitals for all diseases, and the hospital's going to have to decide that this is something they'd like to do. Then they have to learn how to perform it, and I'm sure that probably is not terribly challenging, but that infrastructure needs to be put into place. And then I think the more challenging piece is we're going to have to educate doctors about what it is, what it isn't, when to use it, and how to interpret it. And we've started some internal conversations in my institution about how to do that. And we think that maybe, at least initially, we may have to have some guidance from our maternal fetal medicine department about how the test is used and when it might be used, and how to interpret it. Eventually, this will become quite second nature, I'm sure, but initially, just to make sure that it isn't misinterpreted mistakenly or credited with prognostic powers that it really doesn't yet have. I think there's going to need to be some education and some assistance, even for physicians, in what to expect and what to do with this test.
What Tom highlights is a whole area of science that a lot of people don't talk about. It's called implementation science. It's, hey, we came up with this really cool test. Now what? And there's still a lot of really good questions that are out there. A lot of the data that initially came out with regard to this new test came out in Europe, right? And if you read any papers comparing the populace in the United States versus the populace in Europe, we're shaped a little different. We have different risk factors. And so how those very clinical, very real things play into how well we can diagnose preeclampsia with this new test is going to be really important. But as Tom really put well, it's this idea of architecture, not only to have the machines and the tests available, but how do, simple questions. If someone is concerned about preeclampsia in Boston, where Tom is, the way you apply that test is going to be completely different than if someone does the same test in rural Iowa, where the only university center is maybe 3 or 4 hours away. And so it's these very important questions. So, if I don't know if we're taking bets on an over under, but we still have a few years ahead of us before this is going to be like the troponin, of heart attacks. It's going to probably be 5 to maybe 5 years. I don't know. Maybe even longer. My hope is that the fact that there is approval now, that will accelerate the use and the study of the use of this in the United States.
Well, and I think that's going back to the beginning of our talk. Takes a long time for research to show something to sort of a patient population. I think, how long has it been? 20 years since we've known SFLT1 is a thing.
Yeah, I remember I was a
If-
fellow when those
Yeah.
papers. So yeah, it's been a long time.
Yeah, and obviously we know that UK and Germany have had this for a few years.
And that, Kara, I think that gets to an important point. There were some very, very widely performed and big, expensive trials done right at the end of the 2010s, and with SFLT and with the same set of molecules. But the idea was that these could be used at the beginning of prenatal care to predict whether someone would get preeclampsia later, and they can't. And they weren't successful. I published one of those unsuccessful papers myself. And I think what happened then was interest got really just lost for a long time. And particularly in the United States. In Europe, I think they sort of kept on going with this idea that there was some utility in these markers and that they would go ahead and keep pushing forward with them. And I think that's why where we are now is that some other groups, largely outside of the US, kept pushing forward with the idea, well, maybe if it doesn't predict preeclampsia from the end of the first trimester, maybe it does predict it when someone comes into the hospital. And they kept at it, basically. And I think that's so it gets to this idea that it's, even though it seems so obvious now that this should have worked, at the time it really was it wasn't quite clear what this was going to be good for or how it was going to be used. And it took a long time to work its way through. I think that's part of the reason it took so long, at least in the United States.
We see that with other things too, like low-dose aspirin, right? Low-dose aspirin's been used in Europe for a long time before it started, becoming more widely used here. And I'm interested if Maggie has insight on those sorts of things. But I think to sort of wrap up this particular test, the discussion about this particular biomarker test, it's not going to be available for a while. When it does become available, it's probably going to be in, the university hospital settings first. It'll then trickle down over time to other smaller institutions. Is this something that will ever be used in do you think in, an OB general like clinic, or is this going to be a hospital-based test mostly?
I mean, you could see how it could be used either way, right? We have a battery of tests that your membership will already know, things like liver enzymes and CBC to help figure out if somebody has a severe form of preeclampsia. I could see how eventually this could be both an inpatient, outpatient sort of test. And it's just depending on how they present with the symptoms that make them concerned for preeclampsia.
Yeah.
There's also two aspects of this test which we really haven't mentioned. I think one is that as soon as you get something into the hands of clinicians, they're going to start figuring out what else it can do. Can it also be used to predict other aspects of preeclampsia? So having a new tool won't remain simply within this one very narrow definition. I think there's going to be a lot more out there, and within a couple of years, we'll start to see whether this test predicts hypertension after pregnancy, whether this test also is useful in predicting other forms of preeclampsia or other outcomes in the baby. I think it's going to really mushroom. So that's very optimistic that we're going to get a lot of information coming soon. And I think the piece we haven't talked about that's very important is I'm very optimistic that this test has kind of broken the ice a little bit, that now for the research and in pharmacotherapy, pharmaceutical, and investment community, a test specializing in pregnancy and women's health is approved by the FDA. And hopefully this is just the tip of the iceberg, but it proves for maybe those entities out there that were a little pessimistic about investing in pregnancy research or investing in the pharmacology of improving pregnancy outcomes, that this can be done. There's a product on the market now, or potentially on the market, and that might hopefully open up the floodgates for more innovation, because we can desperately use it.
that is the perfect segue, I think, to talk a little bit more, and Maggie will get to have some more airtime here about research in pregnant people. So, you know, tell me if I'm wrong, the research so far with like SFLT, those are biomarkers as blood samples. They weren't testing anything on pregnant people, right? They're finding these markers. They're looking at, you both, Mark, Donna, Tom, have biobanks, tissue repositories. You're doing research based on information on your pregnant patients that are willing to participate and give you tissue and blood, and you're able to do research from those collections. And I think what we're going to talk about is future research in pregnant patients. And I think this is really Dr. Little's sort of specialty. This is where your expertise comes in. I'd like to just talk a little bit maybe about history of research in pregnant people, or the lack of research in pregnant people, and sort of the ethics around research in pregnancy. We know that we have diagnostic criteria from the 1800s. Is that kind of what it looks like for research in pregnant populations? You know,
yeah, a little too much. Yeah. So, you know, preeclampsia isn't the only disease where there's a real lack of treatments if it's a pregnancy specific disease, because people have been very reticent to pursue interventions, right? I think that's what you were talking about, when we're actually going to give a new medicine during pregnancy. Pregnant women are often told, you know, you can't have sushi, even though the evidence isn't there. Or in England, it was don't eat the lettuce or something like that. So we're just, you don't, very precautionary, don't put anything in your body. I think researchers often have sort of inherited that sense of we're not supposed to give pregnant women anything, especially when we're trying to figure things out. But pregnant women get ill. Ill women get pregnant, right? People have chronic diseases, right? Lupus, asthma, seizure disorders. It goes on and on to, you know, sadly, you know, women who are pregnant or come to pregnancy with cancer. You can't stop treating an aggressive cancer because you're pregnant, or else not only will you die, but your child will be orphaned, right? I mean, this is the world, and that Donna, Mark and Tom know really well, because they deal with high-risk pregnancies. So the mantra is always the best thing for the baby is a healthy mom. And a healthy mom who's got a disease is a mom who's getting treated, right? So you have to think not just of the risk of taking this thing, but the risk of not, right? That's often the worst danger. But of course, we want an evidence base for the medicines that we're going to give to pregnant women. And that goes back to what I was saying about researchers often having reticence. There are a lot of myths and misconceptions amongst the general research community. Obviously, present company are well excluded. Myths and misconceptions thinking that there are always regulations that protect any human subject who participates in research. Okay, because we don't want people to be manipulated or mistreated, or for the risks of research to go unscrutinized, right? We want a lot of oversight on it. But the regulations, in fact, are agree that research is needed on pregnant women, just like any other population, right? And that you can't always borrow knowledge from other sorts of research subjects. The same battle was fought with pediatric research. Children aren't just little short adults; their physiology is different, and they get sick. And so you need to do some research, very carefully controlled, right? Research, but you need to do it, or else you leave them orphaned, sort of second-class medical citizens because they don't have a good evidence base. Same is true with pregnant women. And so the regulations, gosh, I think it was 2001, anyway, got updated to say this research is important. There are special layers of extra precautions that you have to meet for pregnant women, just like there's special ones you have to meet if you're going to do when you do research with children. But they're really commonsensical. They're really doable. That's not really the problem. The problem tends to be a culture that thinks it's somehow unethical to do it, as opposed to the initiative and many people who've been working on this, that it's unethical not to do the research because it leaves women without an adequate medicine. So the good news is, I think there has been the beginnings of a sea change on this. There now, there's a president's commission looking into the issue. If anybody wants really delightful bedtime reading, which I'm a nerd on this stuff, I like devoured, but the president's commission on research in pregnancy and lactating women, I think it was called Preeclampsia, 200 gorgeous pages. I mean, it's so delightful, but really amazing recommendations on things that can make a difference. It started an awareness campaign. Big funders like National Institutes of Health or European medical agencies and stuff have really started to hold convenings and increase funding to this kind of research. So it's a very encouraging time that, sort of like with this new diagnostic test, right? The idea of actually developing potential new therapies that have to be tested while women are pregnant to see if they work. But we don't do those tests until we've already done a bunch of preliminary safety studies. We don't just start animal studies and lots of bench science to understand how the molecule works. We tested in what's called healthy volunteers first, which means not pregnant people with preeclampsia yet. Gather all that data, and when we feel and when people review it and we know it's really reassuring safety data, then we start to do small trials with pregnant women who decide that they want to join a study to try to help make a difference. So yeah, I think it's an encouraging time to be looking at these things.
I think one really important thing that you mentioned is that you have to consider what the risks are of not taking treatment, right? And we talk with our members a lot about their mental health medications.
Yes.
An anti-anxiety medication, or they may be on some other medication for their mental health, or any number of things, honestly. And there's this, the stigma of like, you can't take anything when you're pregnant. And so you need to stop taking these medications unless they're, some class category that you feel comfortable with, whatever that is. And a lot of these medications we have information about because women were sick, right? The sick women get pregnant.
Right.
They were on medication when they got pregnant, and some researcher was like, oh, hey, hey, here are all of these people that were on the same medication, got pregnant, and this was the outcome, right?
Exactly.
And so that's
very clever trial designs, right? Where we don't know that, or people haven't figured out yet the importance maybe of doing the safety studies during pregnancy, but that is a great backup when it's a disease that has a lot of prevalence, so that you have a big N, you have a lot of patients that have been exposed. That's just the medical term. Exposed sounds like it's always scary. It's not. It's like if I, it's a while before you're pregnant, you realize, oh, wait a second, I took a Tylenol. Is that okay? So that's an exposure to Tylenol. That's all it means.
Yeah.
But yeah, that you talk to your doctor and say, okay, now I know I'm pregnant, but I've had lupus. So I was taking my lupus medicine. And then they do big studies of looking at the data, the outcomes from a big set of women who had those exposures to see how she and the baby do. Even if she stopped taking the medicine, then they can look at the time of exposure, and lots of reassuring evidence comes in. I mean, most medicines are completely safe to take during pregnancy.
Well,
It's not an unusual
Just
medicine.
check with your doctor first. Yeah.
No, of course.
Yeah.
I'm just saying that the idea that the default is that it's dangerous is not, when they have studied drugs, the studies usually come out saying that's great, or we have to change the dose or something.
Yeah.
No, I'm not advocating anything. I don't, my husband says
I
I
know.
say a doctor on TV because I hang out with doctors, but no, I'm just saying as a general matter, if it's healthy for an adult human, it's usually healthy for a pregnant
Right. It's
woman.
a benefit, risk benefit,
Mhm.
right? What's the benefit and what's the risk, and which is greater, right? And so I think we're just saying right now we're ending this myth. You know, research can,
Be
happen,
responsibly done with
be
pregnant.
responsibly done. And there are lots of medications that can be safely taken in pregnancy. And you just, especially if your doctor has said, yes, you can take it or should take it, that they went to medical school. They are not trying to put you in harm. They like to keep their medical malpractice insurance low. Right. Yeah. And so if physician, and that comes down to some trust, right? Having a good relationship with your physician, and trusting.
The contemporary model is moving away from a paternalistic sort of, I know what's right because I'm a physician, to what we call shared decision making.
Yeah.
And so the way I see it is the physician's job is really as an educator to teach the patient the pluses and minuses, because there is no course in medicine that doesn't have pluses and minuses. You just need to understand what the pluses and minuses are. If you have depression and you are pregnant, there are very well documented and profound problems with untreated depression in pregnancy. It can lead to a lot of very bad outcomes, very similar to the ones that people worry about with the exposure to medications. So these things have to be understood, both what the benefit of the medication may be, but also the downside of not treating whatever is under consideration. So I see a lot of physicians' roles more as an educator than as or guide, I suppose, than as decision maker for the
Yeah, we have a lot of tools in our group to help facilitate conversation for a pregnant person and their provider, to sort of evoke those conversations. Hey, you prescribed this medication. I read something, heard something, don't feel comfortable taking it. Can you tell me more? Can you tell me why I should be taking this? Can we talk through, my concerns, my fears, why you're recommending it, and come to that shared decision space, right? And then ultimately that person gets to choose whether they're taking something or not, right? That's their choice. But thank you for pointing that out. That shared decision model is not, we don't see it everywhere, but yes, that's we're trying to encourage our patients to have those conversations when they don't feel comfortable with whatever instructions they've been given.
The problem was that it was a catch-22, right? In trying to keep pregnant women safe, they didn't let them be in studies. And then by not putting them in studies, you didn't know if medicine was safe. And then you tried to take things that were fine in non-pregnant men and say, oh, this was fine, and this got rid of their nausea, so let's extend it to pregnant women. And then you had the thalidomide tragedy instead. And so by not putting pregnant women in trials, you were also risking them. And so it's great that the rules have been changed, that it used to be that only if a drug was targeted to pregnant women could they be in the studies, and that was a long time ago. But it's now that it's changed, and have more data on safety profiles for drugs.
And it's encouraging, and there's hope, and I hope that's what we're trying to get through in this discussion, that there's a lot of hope. Dr. Little, Dr. McElrath, the smarter Dr. Santillan, what we're trying to say is that there is true hope here, because as we sit on the biggest funder for a lot of research for many of us in the academic field is the NIH, And there are not, but it took a while for the NIH to get it, but they're there. They're saying, well, sex has to be, or gender has to be a biologic variable. We need, and they force you to address these things in these grants. You have to judge grants. And if you're applying for money through these agencies for a research study to address the real problem that is in women and in men, they're not the same. So there's real hope there, and it's very encouraging. Not to mention the fact that as we've mentioned before, there's a lot more. There is beginning to be more funds and support for pregnancy-related research.
And NIH is National Institutes of Health, just for those who want to go Google it later. So let's roll into this another headline, smaller headline, because it's earlier in the conversation. Comanche Biopharma received FDA clearance for an investigational therapy to administer a therapy to healthy humans. So this would be a non-pregnant person, but the therapy is targeted at preeclampsia. And so they're going to, at some point, start human trials in, again, non-pregnant people of this therapy. Can one of you talk a little bit about this therapy and what it does? We know that it targets SFLT1, which we talked about earlier in our conversation today, this biomarker.
So without trying to get too complicated, because I think this topic could get quite complicated quite quickly, but this is exactly the kind of thing we were talking about earlier, where the development of a biomarker that demonstrates some aspect of the underlying pathology of a disease will help to open up opportunities for therapy. And so what the biomarker looks at is the level of SFLT particularly in proportion to a ratio with the placental growth factor. But in women who have preeclampsia, and it's quite high, particularly in women who have the more concerning and potentially more morbid forms of preeclampsia. And what the medication that Comanche is developing proposes to do is to reduce the level of SFLT in patients who have been diagnosed as having high SFLT levels in the setting of preeclampsia. And the hope is that will actually help scale back any of the symptoms and some of the potential consequences of the condition. So this is exactly one of the reasons why having a biomarker or a test that actually starts to look at one of the underlying aspects of the pathophysiology of the disease is really going to help open up new avenues for therapy. And this is exactly what that is. This is a new avenue of therapy based on a better understanding of the pathophysiology of the disease. Using the 100-year-old diagnostic criteria really wasn't helping us treat patients for more than just temporizing with their blood pressure, or trying to get a few more days to weeks out of a pregnancy by using medications to hold down blood pressure. That really wasn't getting at the root of the disease. Hopefully this is going to start to get more towards the core of what's going on in the pathology.
Thank you for that. That's a great connection between the sort of biomarker test we were talking about early on, that the headline, Thermo Fisher's biomarker test that was announced on Friday as having cleared through the FDA. And now this therapy based on SFLT levels will start at some point here in the near future testing in healthy humans. So this therapy has passed through some animal studies, right? And the FDA has looked at those studies and said, okay, great, so far this is safe enough for us to use in healthy humans, and then we'll wait to sort of see how that what information comes out from that trial, and then hopefully that all is still safe, and then it goes on to pregnant
Mhm.
people
Mhm.
being used in pregnant.
Starting with this, yeah, so if I can sort of remind people or refresh on, the sort of pathway of research, right? You do a ton of bench science, which is what, everybody here has been talking about. And in this case, part of the bench science was, finding out that preeclampsia, at least many forms, happens when the placenta produces too much estrogen. That's what causes a bunch of the problems. And learning about all of that and how the placenta, what is happening that turns up the spigot, right, to unhealthy levels, started to lead to scientific exploration of, is there a molecule, in this case, a special type molecule that could intersect with what that mechanism is and turn it down to healthy levels. Okay. So that's what the hope is, that they have found a molecule that will do that. It's a hope. That means there's a lot of biological research and theory that says this could really make sense, right? And then you do a bunch of work before the FDA says you can start it in humans. That's what you were referring to, Karis. It's been tested in animal studies and the like. Then you try it in somebody who volunteers and says, okay, I'm a woman, I'm not pregnant, but I want to help the cause, right? To see how the drug deals with a human body, right? We've tried it in some other animals, but you have to see, you watch carefully, does it do something unexpected, like mess with kidneys or something like that, right? We just keep testing your blood and things like that. We watch very closely. And with all of that data, then everybody checks that data, very, biostatistician people are staring at this data. And if they give the all clear, which again goes to the FDA, they have to say, okay, then they do what's called first in pregnant women. And they start with a small group of pregnant women and, give enough that they're just trying to see how it acts on the body and how the body acts on it, called pharmacokinetics and dynamics. There's your fun vocabulary for the day. You just need a few women to find that out, right? And then figuring out what dose actually seems to help more and less. And then after you've figured out all of that stuff, you have and you review all the data again, you get the green light, you have more confidence and say, now let's try it in a real group of pregnant women to see how much it might help. So, and it'll take, that takes time as well. And we want to go slowly and deliberately and gather data all along the way. It's very regulated by the FDA and for good reason, right? So, a couple of years, and if the news is good, it'll be amazing.
So the research that's been going on for years and decades and a really long time is bringing us finally these things we can put together, this biomarker tests that help determine these, levels, and then perhaps a therapy. I want to reiterate, this is investigational. We don't have any idea if it's going to actually do what we want it to do or think it might do. The bench science seems to suggest it should, it hopefully will. And we're not gonna know for a while.
It's called research because we're not sure.
We're not sure.
That's why we do a lot of very carefully designed, calibrated research. So we have hope, as long as it keeps going forward, we have reasonable, good, earned hope. But the reason you keep doing it is to have confidence. And not every drug makes it through. Sometimes you think we really thought it would work and it doesn't. And that is why you do the research. But very exciting. As everybody's been saying, even if this drug doesn't work, the understanding of preeclampsia and with this biomarker is such that there, great hopes that there will be only more ideas that come forward and new things to try as well.
Right. So it's the first step, and really, this is the first preeclampsia therapy that's been put out to research in humans in this manner, and that in itself is groundbreaking.
It is. Mhm.
right? That we've gotten to this point that, you know, the FDA has cleared these trials to move forward, and that, you know, hopefully all of that goes well and it moves into pregnant people. This therapy, assuming it gets to a phase of trial where it would be used in pregnant women, would be used in people with a classical diagnosis of preeclampsia. Is that correct? And then from there to see what can it do? Does it buy time for that mother and baby? Does it stop all of those symptoms altogether? We don't really know. We don't know what's going to happen. We don't know if it's going to work at all. And again, this is not something that's going to be available to anyone because it really is still very much being researched. But there is so much hope in all of this, and I appreciate you all being here today to talk about really the massive amount of research that is happening in preeclampsia. The ethics behind, we're just making it a statement here. It's doing research in pregnant populations is
Moral imperative. It's a moral imperative.
Is a moral imperative. And I hope that hits home with our all of our members as they see these research trials come out, as maybe they want to participate in them. They can go out and talk to their MFM, talk to their OB. They can go to clinicaltrials.gov to see what might be going on near them that they might participate in. They can write letters to their hospitals. Maybe we can put out a draft letter that everyone can send to their university hospitals to get these biomarker tests in use in their locales. And that there are lots of really smart, great, amazing people like all of you here on this screen who have dedicated your careers, your lives to maternal health, just to cover that loosely, because I know you all do a lot of things, not just preeclampsia. And we appreciate, and there are thousands of others just like you out there working towards better outcomes in pregnancy, in particular this population. So I'm very grateful for your time, for your dedication, for your work, and for this chat today, to bring this information, make it a little more accessible to our patients, our members, and I think all together we can work together to continue pushing all of this forward, and in general, hopefully reduce the maternal morbidity rates, mortality rates, particularly here in the US. And then, of course, we hope that by these things being adopted here, that they will be adopted in other places as well in the future, to help moms and babies all over the world. Thank you so much for your time. Have a great night.
It was great to chat with all of you.
Thank you. Great to chat with
Bye
you.
now.
Bye, guys.